Good afternoon and welcome. Thank you for joining us today for our training and introduction to creating a trauma-informed culture in the post-acute and long-term care facility. Part 3, Trauma Screening and Trauma Assessment, Why the Difference Matters, hosted by the Center of Excellence for Behavioral Health in Nursing Facilities. I am Nikki Harris, Training and Education Lead for the Center of Excellence, and it is my pleasure to oversee the delivery of mental health and substance use disorder training and education to nursing facilities nationally at no cost to the nursing facility. We have a few housekeeping items before we begin. This session is being recorded. We ask that you only use the chat box for asking questions or providing your feedback. The slides will be made available to you. I will place the link in the chat towards the end of the training. We also ask that you complete the post-test survey as we conclude today's training. And now, it is my pleasure to introduce our presenter for today, Ms. Paige Hector. Paige is a consultant, nationally recognized speaker, and author with over 25 years of experience in post-acute and long-term care settings. She specializes in diverse topics for the interdisciplinary team, person-centered trauma-informed care, nonviolent communication, sustainable process improvement, and advanced care planning. Paige writes extensively on topics relevant to nursing homes, including multiple chapters of Managing the Long-Term Care Facility, second edition, due for publication in 2023. Paige is currently the associate editor and a regular columnist for Caring for the Ages, the publication for AMDA, the Society for Post-Acute and Long-Term Care Medicine. In 2018, she was named the Gerontologist of the Year for the Arizona Geriatrics Society. And now I'll turn it over to Paige to begin the presentation. Thank you.
Hello, everyone. Good morning, afternoon, wherever you are in this country, and I welcome you. My name is Paige, and I'm delighted to be here. So we will be talking about trauma screening and assessment. And just to kind of orient you, this is part 3 of a 4-part series. So let's dive right in. Just to do a quick recap, what we've already covered in parts 1 and 2. So we took an enormous amount of content, broke it up into 4 sessions. So today we're focusing really just on trauma screening and assessment. But before, in parts 1 and 2, we've covered all sorts of other content. So I encourage you to go back and listen to the recordings. We talked about definitions and sources, the impacts of trauma, the difference between reactions and behaviors, that trauma is cumulative over a lifetime. So there's just so much content that we've already covered. So today what we're going to be talking about is the difference between trauma screening and assessment and why this distinction is so very important. I'll be talking about 2 different screening techniques called direct and indirect, and how we're actually always using indirect screening. And then we're going to be talking about different things that we can do as staff in the event that a resident or a person chooses to disclose any details of a traumatic experience. All right, so let's dive right in. This is one of the mindsets. Trauma-informed care really is, it's not just the things that we do, but it's how we think and how we approach situations. So the mindset shift we're talking about here, to me, it's like a paradigm shift. Instead of asking a question, well, what's wrong with this person, which really is in medical centers and medicine and nursing homes, we tend to look at problem lists and we look at medical diagnoses. So what's wrong with the person? And we're shifting that mindset and our lens that we approach the individual to what is the impact of past experiences on the current presentation. And that language right there is really important, on the current presentation. I'll be talking a lot about that in just a little bit. So what has happened in this person's life, and then how is it affecting them, is really the framework that we're looking at that is the foundation for trauma screening. So what is the difference between trauma screening and trauma assessment? Well, the way I like to teach this is that screening is brief It's used to identify whether an evaluation or further assessment is actually indicated or necessary. So here's a few examples that I know all of you are going to identify with. We do a PT screen, a physical therapy screen, excuse me, to identify, if a person is walking, transferring, and doing well, and there's really no risk of falling, there's probably no indication to pursue a physical therapy assessment. If a hemoccult test indicates that there's no blood in the stool, it would not be wise then to pursue a colonoscopy. If we do a PHQ-9 and indicates that there might be some suicide thinking, then it would be appropriate to proceed with a suicide assessment. So one informs the other. The screening informs whether or not we assess. It's the same with trauma. So there's two different ways of looking at this. So we've got the trauma screening, and everyone in that area would be called a generalist. To me, that's everybody. When I say everyone, I mean everyone. Maintenance, housekeeping, dietary, departments and individuals that we don't necessarily associate with the clinical operations in a nursing home. So everyone receives training about trauma and trauma-informed care and how to interact with someone and how to respond to someone in the event that they become triggered. So that's all kind of very basic information. The generalist, however, does not treat trauma, does not assess or treat trauma. So over here, to me, this is really, I'm going to say most of us on this call, myself included, even though I'm a professional social worker, master's prepared, 30 years experience, I do not assess and treat trauma. I would screen for trauma, which also includes identifying triggers, creating a culture to minimize any chance of re-triggering or traumatizing another person. And then we make referrals to mental health specialists as needed. The other part here is assessment and treatment. So these are individuals who are clinicians, psychologists, psychiatrists, behavioral health professionals, social workers, any number of degrees that are specifically trained. And I want to take this a step further. I just got curious. I like, what are some of the competencies for an individual who is actually skilled and trained to do assessment and treatment of trauma? Well, they would be capable of doing things like understanding the differences between the different types of trauma and the impact on the human development, the role of protective factors that can prevent and ameliorate the impact of trauma. So there's also this understanding the psychological and the substance use issues, which are often associated with people who have had traumatic experiences, how trauma affects diverse people throughout the lifespan, knowledge of the impact of trauma on diverse cultures. So there's just so much. So I really want to make it very clear, the generalist and the specialist are two very distinct, not better, or they're just different capacities, different competencies. There's many different treatment modalities. When we talk about assessing trauma, this is a partial list. I just did a little research, like what are some of the modalities? So there's many different skill sets and different treatment modalities that a person who is trained would be probably capable of doing these things. So what I encourage people to do is what is available in your community, in your area. So once we talk about screening here in a little bit more depth in a moment, I really encourage you, what is available? Are there companies or individuals within your network, within your region, or even online that you would feel comfortable that in the event that you indicate someone is needing and receptive, that they give their consent to have treatment around trauma, then you want to know what's available in your area. So the generalist will focus on the impact, and I will come back to that over and over. The generalist focuses on the impact of the traumatic experience, not the event itself. That's a very, very big difference here. So when we go digging for trauma memories, when we go digging by asking a lot of questions, what happened? What did you do then? What happened then? That actually can stimulate triggering and re-traumatizing the purpose that could be very harmful, re-traumatizing the individual. So instead, what we're looking for are the signs and symptoms that are showing up that might indicate that there might have been something in the past. So one of the tools that I'd like to provide to you that Nikki will, I believe, pop in the chat box for you, This is called the delayed reaction to trauma. It's a worksheet. I encourage you, it's free for you to use. It's something that some colleagues of mine developed, and this will be published in that textbook that will be coming out hopefully later this year. So what you'll notice here is there are, in this particular worksheet, there are 5 different categories. So you'll notice it's consistent. Possible delayed emotional reactions, physical, cognitive, behavioral, and existential. So this is one of those worksheets that really, I believe it could be a very helpful tool as you go into your interdisciplinary team meetings, your stand up, stand down, your care conferences, whatever format that you use. I would love to see you all integrating this worksheet into your daily operations and workflow, because it kind of puts everything into one area. So if you notice that a resident, an individual is experiencing any of the symptoms in this category, there's a pretty high chance that they've got delayed emotional reaction to something that might have happened in their past. Could have been yesterday. It could have been the past from dozens of years ago. You'll notice here that the word source accompanies each of these categories, and the purpose for that. If I'm interacting with the individual directly, they would be the source. The patient would be the primary source, or the resident. If perhaps I'm talking to a partner, a spouse, an adult child, the source would be that individual. So that provides a little bit more information. Some of the areas of concern with trauma-informed care. This is a fabulous article by Dr. Barbara in, it was in McKnight's. So I just want to point out some of these to you, and I'd like you to encourage you to think about, well, how might we mitigate some of these in our work setting? So in-services do not make up for ongoing training. I'm a huge proponent of not only do we need some training in initial in-services, I really love to see that we integrate this by coaching and ongoing training, because these are huge concepts, and one training is not going to magically gift us with the mindset, the skills, the words, and the knowledge to be able to integrate trauma-informed care. There might be cultural and generational differences. So we might have someone perhaps who is very young, interviewing and screening someone for trauma who is many, many years their senior. That can, not all the time, but it can create some discomfort or not quite understanding the generational differences. Same with culture. There can be very little privacy, and sometimes there's things that can be overheard. We all know what it's like to try to do provide privacy when we're in a shared room experience. So we need to be very cognizant of that, and especially in smaller towns. I know here in Arizona, we have many nursing homes in very small rural communities, and a lot of people know a lot about one another. So we just got to be very diligent and intentional about maintaining privacy and confidentiality. Some of these are very personal questions asked by people for whom there's not yet a relationship of trust that's been established. Very personal details that are now going to be available some degree in a medical record. So we got to be conscious of security breaches, and then sharing of those records with other either up or downstream, perhaps going back into a hospital or being discharged in home health or a hospice might need some of this information. And then the other feature here that I will not address in this session is that staff that administer trauma screening, could also become triggered themselves. So a whole nother part of this bringing trauma-informed care is how do we care for and support each other, the staff who also have trauma histories. There's a few other barriers, as if the first slide wasn't enough. Here's a few more. Screening is not a standard part of our standard intake process, so you really have to be intentional. How do we plan to bring this activity on board? Who will do it? When will they do it? How are they trained to do it? What will we do with the information once we have it? We might underestimate the impact of trauma. Remember, I've taught before that trauma is cumulative. So everything that has happened up until the day of today in your life, it would be a cumulative experience of all those traumatic, emotionally, some of them very sensitive experiences. So we might underestimate the impact of that. Not knowing how to respond when a person shares very detailed, sometimes very private, vulnerable information, the staff might be, oh my gosh, I don't know what to do with this. Fear that the trauma inquiry might be disturbing to the individual. It could be, if by asking these questions, if we inadvertently trigger someone, what would the staff member do at that point? Concern that the individual require treatment that the facility can't provide. So that's where I talk about, make sure you've done your homework. What is available in your area, your region, and online? Untreated trauma symptoms of the screener, I've mentioned, and there's a perception of not enough time. So we've got to find a way to integrate all of this new material and content in a way that doesn't already overburden a staff that's really stretched beyond 100% of their capacity. So here's Dr. Barbara, and I really enjoyed this opening in one of her articles. She says that, in my opinion, the good intention of increasing awareness of mental health issues would be better served by evaluating every resident for psychological services upon admission, the way each resident is assessed by rehab, recreation, and other departments, while simultaneously improving the training of staff to refer residents after events such as a decline in physical functioning, a loss of a loved one, or a change in behavior. This was an aha moment for me. So we are accustomed to doing all sorts of screening and assessments and tools upon admission and every quarter. It had never occurred to me, even as a professional social worker upon admission, to screen everyone for psychological services. So this really made sense to me. So staff with good training, absolutely, no question, we can develop and grow our capacity to screen for trauma. And this is a really key point here, the first bullet point. The chances of being traumatized by a properly administered screen are far lower than the chances of re-traumatizing a person if we do not screen. So we definitely want to proceed with this, and we are required to do trauma screening. So I just want to give us some relief that with proper training, we can develop our skills and capacity to do this, as long as we're exercising caution and being mindful what we are asking people. Just talking about trauma does not create an instant catharsis, some side of relief. That just because we name it and talk about it doesn't mean that it's magically all better and fixed. That obviously doesn't happen that way. Be prepared to respond with the next step. So I'll talk more about that in a little bit here. So while staff are trained can provide the screening, they need to understand their role is to provide validation and supportive responses, not to go digging and uncover or explore trauma memories. Again, that would delve more into the role of a specialist when we do evaluation and assessment and treatment care planning protocols. How do we open this conversation? So here's a few prompts. I won't be reading these. You can look at them on the slides later. What I encourage people to do is find the language that works for you. Find the language that is comfortable for you. So there's a few ideas here. Mix and match, play around with it, practice on one another. I really encourage you to practice doing this. And before you go in and try doing this process or these tools with someone, if the person at any point says no, that they are not open or not willing to engage in this conversation, what I say is to respect the no. Respect the no, document it, and then it doesn't mean that we don't continue trying or do indirect observation, but we certainly do not push at this point. There's no pushing, there's no agenda. Another key component of trauma-informed care is the importance of perceptions. So it's important to remember that what happened is not nearly as important as what the trauma means to the individual. So for example, all of us on this call could experience the exact same event. I might have a different experience than some of you. There may be overlap and similarities, but it really depends on each of us, our stage in life, our past experiences. So many factors go into how we interpret the experiences that we have in life. So it's very important that whatever the individual says the trauma is, that's what it is, even if it's markedly different than your perception or how you might have experienced something. So before we delve into screening tools, I want us to look at some strengths-based questions. I want to give you more ways to engage in conversation around this that really is related to trauma screening, but really supports. So when I think of trauma-informed care, to me, it's very person-centered, trauma-informed care. And as a social worker, my lens that I also bring to this is a strengths-based and resilience-based framework in my mind. So again, we have a shift here. It's from what is wrong with you to what has worked for you. And that goes to all of you on this call as well. So here's a few questions that I kind of handpicked to create a slide here for you. Ask people, it's just a juicy, wonderful, yummy question. What do you say your strengths are? And just listen to people. It's really fun to hear what they say. What are some of the accomplishments that give you the most pride? I have a colleague from years ago. She'd say, what are some of your pride moments? You know, what are the things that just bring up that wellspring of well-being and goodness that just make you want to tell people about them? How do you manage your stress today? Love asking that question. How do you do it? What works for you? What behaviors have helped you survive or cope with your experiences? Characteristics that have helped you manage these experiences and the challenges they've created? And how do you gain support today? There's so many different ways of asking these sorts of questions here, but what we're looking for is the resilience model, which is very closely tied with person-centered trauma-informed care. We're looking for ways that people have experienced stress and trauma and distress in their life, and then we're looking for the moments of how did they get beyond it, or how did they cope, how did they deal with it, and we're trying to bring those elements into their experience here in your nursing home. Everyone has strengths, every single human being. Even an individual who is comatose, I can still find strengths for them. So here's just a partial list here. So as you begin to identify strengths, what you want to do with them is incorporate them. Think of ways that we can incorporate these in the day-to-day interactions at the bedside or wherever they are in your nursing home. How can we support our CNAs and our staff, our clinical staff and non-clinical staff, to use these things to create that trauma-informed environment that supports the well-being of each person? So just a quick story. I read a ton of care plans, and one of the care plans, what they had done was, rather than a problem or focus statement, they had actually made it something around strengths, and they had just listed the strengths. So I loved the intention behind it, but what was missing was the integration of the strengths. Rather than just plopping them on a care plan that said strengths, instead weave them throughout. 2 more questions to consider asking. Now, these specifically uphold principles of choice and empowerment, which hopefully by now you recognize as two of the trauma-informed care principles. What information would be helpful for us to know about your experiences and how they're impacting you now in your life? Do you notice there, I'm not asking about the event itself, but I'm asking about the impact. It's not our job to fix things that have happened in people's life. Our job at this point is to understand how they're affecting people now at this stage of their life. Next question. From your experience, what responses from others appear to work best when you feel overwhelmed by your emotions? Love this question. Now, this really is touching on, and I'm going to go into some nonviolent communication, empathic communication here towards the end of our time, but this is really beginning to touch on that. What responses from others appear to work best when you feel overwhelmed by emotions? So love that question. I encourage you to practice on each other, weaving that into and seeing how people respond, and then how you might then respond after that. There is another possible question here. You could ask something around, what information would be helpful for us to know about what happened to you? Now, the reason I say that that's a possible question is because it's moving a little bit more towards asking specifically about the event. One more time, what information would be helpful for us to know about what happened to you? So I'm not specifically asking about the event, but I'm asking a little bit more. So is there something you want us to know that would help? What I'm looking for with that question is what might trigger this person to feel angry or upset or frightened or not very safe. And I'm looking for that to try to mitigate, ameliorate, avoid doing those particular things. What else can we do? Well, like I've kind of said, look at the strengths and triggers, include them in the plan of care, communicate them with staff. I think we've gotten pretty good at creating some of the elements of care plans, but I still see it as a very static, regulatory-driven document, really the care plan to be It's like the blueprint of what to do for this other human being. Sometimes when I teach on care plans, I ask people, what are the 5 most important things that you want me to know about you? If you were to come live with me, what do you want me to know about you? So I really try to bring that person-centered element into the care plan process. And then what we do is we modify the environment. So what we're doing is, what are the triggers? What are the things that we can do to modify and change up the environment, which includes the physical environment, includes how we approach people, maybe some things that we do or we don't say. How do we change up the environment and how we approach people to really bring in that element of voice and choice and safety and trust and empowerment, all of those trauma-informed care principles. So that's what we would do with the answers to the questions that I just showed you on those previous slides. One more idea I want you to consider. I began asking myself when I was first working with this content a couple years ago, I kept saying, well, what are staff already doing that might support trauma screening? And guess what? There's some things that you guys are already doing, that might support trauma screening. I just want to change it up a little bit and invite you to see things with a different lens. The MDS is one of them. So what I did is I went through, Evan, I'll show you a slide in a moment, but I went through all 18 item sets. And I know that we're going to have some changes coming up with the MDS in October. But I began thinking with a trauma-informed lens, signs and symptoms and events that might trigger or simulate a traumatic experience. So when you look at the MDS, if you can think, wow, could these things be a sign or a symptom or an actual trigger trauma event for a person? And then I just ask you to consider, what other things might you already be doing that would support trauma screening? So here's a little bit more detail. So we all know that the MDS, this is nothing new. But if you were to take a look at some of those item sets, like delirium, behavioral symptoms, ADL, bowel and bladder care, all of these things may be connected to, related to, a result of a traumatic event. So what I'm asking you all to do is when you do your MDSs, kind of come at it with, could this or might it be related to? So consider if that information might be a trauma trigger, reaction, or a source of distress. At the same time, don't assume that just because a person has a particular condition or a particular experience or a particular reaction, notice my language there, I'm not saying behavior, I'm saying reaction. Don't automatically think it's related to trigger or to a traumatic event, but your question, you're thinking along those lines of, could it possibly? Okay, so now let's delve into actual screening processes and tools. So I indicated one of our objectives today is to look at 2 different types of screening, direct and indirect. No matter what we do, no matter how we screen, it will not capture everyone up front who has experienced trauma. Sometimes people who have had traumatic events in their life, they don't identify them as such, or they have not linked it together that the experiences they're having in their current life experience might actually be related to something. So this is a very, very complex topic. Capacity determines strategy, not exclusion. What does that mean? It means that we screen everyone for trauma. It does not matter what level of capacity. The person who is living with the most advanced form of dementia or traumatic brain injury or who is comatose, we will still screen for trauma. We might do it a little bit differently, but just because they have limited capacity for whatever reason doesn't mean that we don't screen. An actual screening tool, and I'll show you one in a moment, a tool itself may not be appropriate, especially if the individual does not have capacity to engage and answer questions, or perhaps they don't have family or involved responsible party people, individuals that can help support us with learning more about their experience. There may be indicators for staff to act as if, another super important principle of trauma-informed care. That's really hearkening to the universal precautions idea, is that we will always act as if. We bring that trauma lens and that mindset to everything that we do. So if they are experiencing some kind of stress, we're going to say there could be some kind of link here. So we're acting as if at all times. Indirect screening, we're always engaged in indirect screening. From the moment that a person moves into the community, day-to-day interactions, what we're doing here is we're paying attention. We're paying attention to what people say and what people do. And with that trauma-informed care lens, we're wondering if, could it be related? Is there something that's happened in their life? For people who have cognitive impairment, or for people who are not cognitively impaired, but who clearly say, no, I'm not doing some kind of screening, we still engage in indirect screening. It's just part of our, how we bring our expertise, no matter which discipline that we're involved with, how we bring that to our everyday work. Once we have trust, once we've gotten to know a person and they begin to trust us, it might be appropriate to reapproach direct screening if in fact they have capacity. If the discussion indicates the presence of symptoms of traumatic stress, ask if they're interested in further evaluation and assessment, and if so, we make the referral. So here's just a few things. Like if you hear people, residents and or family members, saying things like in the italics here on the top part, I lost my soul, if I had just, that really brings up that element of grief and regret and mourning. If I had just done this or that. It seemed like my brother was missing. My son, daughter has never been the same. And you can mix and match. You can, my partner, my spouse, I have never been the same after. So these are things that indicate that there's something that happened in this person's life. And again, we don't go digging for the memory, but we see how it's impacting them today. At the bottom here, if you were to take a look and just did a quick screening or a quick audit of all the different diagnoses that people living in your community are dealing with, if you find that they have specific, well, obviously PTSD or any sort of mental illness or addictive use disorders, those are going to indicate that there's a strong, high likelihood that there's been some trauma in that person's background. So these are things here to be aware of. If you hear any of these statements, you ask, could it be related? So then we have direct screening. Now, this is suitable when the individual has, so two parts here. They have capacity and they consent. They are in agreement to being asked these particular questions. Or the other thing is, don't forget that we can print it out and we can actually give them the particular tool to ask them to do it themselves. This does not have to be an interview type of process. There's many different ways that we can screen for trauma. So before I show you the screening tool that I do recommend, I want to show you an example of something that I feel concerned about. So this is a brief trauma questionnaire. It isn't a well-known EMR program, and I have zero doubt that many of you on this call right now are going to recognize where it comes from. And I want to be careful here. This is not about identifying a particular software or anything of that nature. I'm simply pointing this out because this, and you'll notice here, I'm just going to read a couple of these prompts. So it's a bit difficult. This is a screenshot. It's very hard to make it big enough. So for example, number 2, have you ever been in a serious car accident or a serious accident at work or somewhere else? You'll notice right away that is delving in and going right after an event. Every single one of these do. Before age 18, were you ever physically punished or beaten by a parent, caretaker, teacher, and it goes on. Have you ever been in a situation where you were seriously injured, or did a family or close friend die violently? Please don't ask these questions. This is not considered trauma screening. This is not what I would consider would be an appropriate tool for a generalist to be asking of a resident or patient in our communities. This might be more appropriate if the individual had agreed and was pursuing trauma-specific cognitive behavioral therapy or any other modality specifically targeted at assessment. So imagine, just for a quick check here, imagine you being a new resident or patient in any kind of a long-term care. Maybe it's to live or for rehab or assisted living, if we have any of our AL folks on this call. Imagine someone asking you these very personal, private types of questions. I personally would not feel comfortable answering this questionnaire with someone that I have no history with. I have no idea how they would use the information and what it would mean. So intentionality and exercise caution what we are asking people. So what do we do instead? Here it is. So this is called the Primary Care PTSD 5. This is a validated screening tool. This is, I will just say that I'm on some national work groups around trauma and trauma-informed care. My colleagues we agree that this is the tool that I believe is the best tool to use in our settings. This is what it looks like. It's the reason it's it's 5 questions. It's pretty simple. In the past month, have you? And then there's 5 questions. Now, I want you to notice the difference. It does not go and ask about a bunch of events, life events. What we are doing here is asking about the symptoms. Have you had nightmares? Have you had hard not to think about? Have you been on guard, watchful, easily startled? These are the signs and symptoms of indicating a potential past event. Scoring yes to any 3 of these 5 indicates optimally sensitive to probable PTSD. This is not a diagnostic tool. This is a screening tool. If the person indicates yes to 3 of 5 of these, you might want to consider pursuing some kind of assessment if they are in agreement. Now, I want to take this a step further and notice an adaptation to the PCPTSD-5. I highlighted it here in this brown text. So the original document said here, in the past month, have you? This adds a sentence. In your life, have you ever had an experience that was so frightening, horrible, or upsetting that in the past month? Do you see what we did here, folks? What we did is we've acknowledged a very important part of trauma-informed care is that trauma is cumulative across a person's lifetime. So that few words in that sentence, tacking that on, that recognizes that have you had an experience that was any of those that in the past month you have had, same 5 questions. I prefer this version of it because it really brings in that historical component as well as the cumulative impact of trauma over a lifetime. Okay. The other thing I want to point out here is you'll notice that we have source. The reason that we've adapted this tool in this way is that because if the individual is either not cognitively capable or willing to engage with this particular screening tool, if you are asking a partner, a spouse, an adult child, or some other person that knows them, you would indicate the source would be how you got the information. Okay. What do? We've done a screening. But we've got to have a process now. So when we do the screening, we need to have a procedure for what to do in the event of a positive screen as well as a negative screen. So the screening is only as good as the actions taken afterward. For an analogy, can you imagine doing a fall screening or a bowel and bladder screening or any type of screening that indicates we might have a problem, but we don't follow up with it? It's the same mindset when it comes to trauma. So there's a couple of prompts on here. I just encourage you, make sure that you do have a policy in place for trauma screening and then what your staff would do in the event of a positive and a negative screen. A no does not necessarily mean that there is no indication that there was a trauma or impact today. It just means that they may not be willing or they may not have recognized that there's a link there. If the individual chooses to share the details of a traumatic experience, let them know they don't have to talk about it. I just want to make sure that we are preparing staff to be going in and asking some potentially very private, vulnerable types of questions of people. So there's some prompts here. And then at the end, Nikki will also provide, I have a 5-page handout I developed in conjunction with a couple other colleagues that really wanted to try to help support you, that in the event that they start talking about an event, because some people will be very comfortable with that, which is fine. Some of the things that we need to be able to do as staff is assess current safety. So if I'm working with a person and they're sharing an event, for some events, I need to probably determine, is there any indication that there could be an unsafe component here, perhaps a domestic violence situation or something that might still be impacting them while in your community. So it's not a matter of delving in and asking a lot of details, but assessing current safety, making sure privacy is upheld, especially if the information is unusual. Not everything that people tell us needs to go in our documentation or the care plan or to be shared in an IDT or some kind of a meeting. Document all known or suspected triggers. When you are done with the conversation, be sure to ask how they're feeling. The prompts that I'm going to give you in just a few moments with empathic listening can also help you. So don't just like, okay, thank you for sharing. You want to check in and reconnect with them. How are you feeling in this moment? And then listening very deeply for that, because you don't want a person to become stimulated or triggered or agitated, and then you end the conversation and just kind of leave them in that activated state. So in part 4 of this series, I'll be talking a lot about grounding practices. So this is where you would be skilled, hopefully, and have capacity to bring those grounding strategies in the event that the person becomes stimulated. Okay, couple things here. Sarah Payton is one of my favorite teachers in this space. She's a neuroscience educator, fabulous teacher. She says that trauma is less defined by what happens to us than by how we are received afterwards. Isn't that incredible? That the event itself, while certainly important, but it's how we are received after the event that really indicates the extent of how traumatized we will be, perhaps in the moment or across a lifetime. This next question, or this next statement here, when painful things happen, the most significant question often seems to be, does anyone believe me, notice me, or care about me? Does anyone believe, notice, or care? This is why empathic listening is so incredibly important. So I'm excited to be delving a bit, and I'm doing a very brief snapshot of a ginormous topic of empathic listening, compassionate communication, nonviolent communication. So I want to bring some of that to you, because to me, this is how we bring person-centered trauma-informed care principles to life. We've got all these principles: trust and transparency, safety, voice, choice, and empowerment, collaboration, and mutuality. So they're principles, but how do we bring them to life? Well, to me, the answer is nonviolent communication. So empathic listening, it's a quality of understanding another person's experience that provides warm accompaniment without judgment. So my colleague Aya is one of the people, this is my favorite definition of empathic listening. Sometimes people say, well, empathy is just walking in the other person's shoes. It's not just that. It's not that I want to feel the feelings you're feeling, but the empathic listening is, I'm going to accompany you. I think of two musical instruments. If I play a violin and I have another violin sitting next to me, the second violin is going to vibrate when I play the first violin, even without touching it. That's the idea of accompaniment and resonance, that we are actually accompanying another human being as they are feeling the feelings that we're feeling. I'm not feeling them for you. I am accompanying you on your journey. So in order to give you some examples of how we do that skill, I want to first give you some examples of things that we tend to do that are not empathic. And I want to bring, before I bring the slide up, I want to say this to you all. We are conditioned, we are socialized to do the things that I'm going to show you on this next slide. The way that we are socialized from very, very young ages, all the way through school, all the way in our families of origin, that these types of responses come very easily to us. This is our cultural conditioning, our societal training, that we tend to do things. So when another person is in distress, or they're upset, or they are crying, or they are angry, we are socialized, all of us, to come at them with statements that actually create more distress and disconnection rather than connection. So this is a list here. If you'll notice here in the bold, a very popular choice is to offer advice. Just think about this. How many times have maybe you've been upset about something, or even just mildly irritated or frustrated, and you go to tell a partner, a spouse, your best bud, and they come at you with, well, I really think you should do this. And you're like, wait a minute, I really didn't want advice. Minimizing. So that would sound like, well, at least you've got this, or well, at least. Anytime you hear that, well, at least, there's an indication here that there's not an empathic connection. Changing the subject. This is very useful when the person receiving the information is uncomfortable. And one of the strategies was they're gonna divert. They're gonna change the topic, the subject, because they may feel uncomfortable. Trying to see the bright side. Anytime we hear things, the gift in this, the silver lining, that kind of language. I'm not going to go through all of these, but I want you to take a moment. I always love when I'm in a big group of people. You can pop it in the chat box if you'd like. We can play with this a little bit. Which one of these is your go-to? And we all have them. And again, this is where I bring a little bit of fun to it because we can see ourselves in these, everyone. Folks, there's nothing wrong with these. I'm not blaming or shaming anyone, but I'm saying this is part of the challenge of not being able to bring empathy to people, is because we are so trained and socialized to do these things instead. So if anyone's interested, go ahead and pop in the chat box. Which ones of these do you all do? This is horrible, Sumaria. This is horrible. I don't know what to do. So catastrophizing, yeah. In a way, I wanted to say that there is a way, but it wouldn't probably be to that. Samaria, what we're going to do, rather than going that, oh, this is terrible, we're going to do some empathic listening first. Reframing, seeing the bright side. You're being negative, so bright side, minimizing. Yeah. I just thank you for acknowledging this is vulnerable, because what we're doing here is we're saying, Angela, storytelling. I've done that as well. This is part of self-empathy, that we're saying, ooh, we've got these responses. They were given to us. We were trained to do these things and we're really good. Yep, storytelling, Rebecca, reassuring. I found that the more I worked with this stuff, I was really along the lines of an interrogator. I asked a lot of questions, dismissing everything happens for a reason. Okay, so again, play with this a little bit. So thank you for putting your responses there. So learning nonviolent communication skills, how can we do this? Let me introduce you really quickly. So NVC, this is the classic book around NVC. There's dozens of books, and at the end of this webinar, I have oodles of resources if you are interested in pursuing some of this for your own community. So NVC is a set of skills that supports a communication model based on empathy. Before I show you the connection between trauma-informed care and NVC, I want to talk about this first. One of the foundational principles of NVC is this idea of human needs, that no matter who we are, no matter our age, no matter our socioeconomic background, our race, our gender, how we identify, every single one of us as human beings has human needs. And every single thing we say or do is an attempt to meet those needs. Let me show you. Here's a list. So Nikki's going to have this and she'll pop it in the chat box. I do believe, if not, it'll be available to you. This is a list, and I'll pull it off of my desk here. I keep it all times. Listen, it's laminated. I keep it with me. I refer to it constantly. If I'm in a conversation, before I prep for a meeting, before I do an email, I'm constantly looking and asking myself, what is it I'm feeling in this scenario and what is it I need? Because that helps me to bring my authentic self to this work. There are so many different needs here, and I could go on hours and hours just about this one slide. So introducing you to the idea that we all have these needs, which means the people that we're working with, the patients, the clients, the family members, each of us have all of these needs. Your partners, your spouses, your kiddos have these needs as well. When our needs are met, let me rephrase that I'm going to talk about core human needs really quickly. I'm trying to do so much in such a little time. We have core human needs. So these are some of the needs, and especially related to trauma. When we do not feel heard or understood, or we are not acknowledged or have choice or feel like we matter as a person, there's just something that happens to our essence as a human being. So people who have experienced trauma likely did not have these core human needs met. Something happened to them in their life that was very distressing and frightening and horrible, and traumatic, there's a very good chance that these core human needs were not met. So this is important for us to understand when they come into our communities. How can we create an environment that helps them trust and feel safe and to be heard and acknowledged and understood and to be back in choice? Think about all the times when you've not had choice about something and you have maybe some resentment bubbling up or some fear around that or anger around that. Another important part, so we've got the needs, we've also got the feelings. So here's how I want to teach it to you. We do a really good job in healthcare most of the time of figuring out if a person says they have physical pain, we're going to ask questions. Where is it? What's the quality? What does it do? Can you describe it to me? What makes it better? What makes it worse? The physical pain gives us very important information. It's the same for our feelings. The feelings are like a compass. They point us in the direction of what we need. So we've got the needs on one side and the feelings on the other side. And you're going to notice on this worksheet here, this slide, feelings when needs are fulfilled or met, and when they are calling for our attention or not met. Please notice, I did not call them good or bad, positive or negative. Let go of that polarized thinking. That's been socialized of how we think about things. Good, bad, right, wrong, appropriate, inappropriate. What we're doing instead, the feelings that I have inside of me give me important information about if my needs are met or not met. So how can we integrate this into our work to bring empathic listening to people in screening for trauma, or just, to me, it's everyday interactions with everyone, with our residents, our patients, and one another. What we do with this information is we connect what they say and do to what they might be feeling and needing. So this is a very simple slide. I'm just trying to give you a taste and some prompts that I'm hoping you can take back and begin playing with. So we offer guesses to get more understanding and to connect. So the basic prompt is this. Are you, and you put a guess of a feeling in there because you need, want, or would like, and then you put in a need. It's important here to understand there's no right or wrong. This is not about getting gold stars or extra points for guessing correctly. Let go of that. The purpose of this beautiful sentence is to connect with another person. If I'm working with a person and they're becoming, in my interpretation, agitated or upset about something, I might use, are you upset because you might want or because you need? And I put some prompts in here and you can mix and match. And as you get more fluid with this language, it becomes a lot easier. And then the very important thing here is you ask at the end is that it? That's a lovely, it's what we call a connection question, because I'm going to ask, are you feeling this because you might need, want, or would like this? And then they say yes or no or whatever. Or I might say, is it this because of that? And I say, is that it? Did I get it? It's my sincere, authentic wish and intention to connect with this person. And by saying, is that it? It gives them the welcomeness to say, no, it really wasn't that I was frightened or upset. It was more like this. Oh, lovely. Okay, let's talk about that. So it's just a way of connecting with someone. And an empathy guess is always a question. So you would say, I'm wondering if you are feeling a feeling because you need. It's not this way. It's not, well, I know you're upset because you need understanding. That's such a different feeling and energy to it. That's not what we're doing here, okay? If I were to say, it sounds like you're upset, I'm guessing you want understanding. Even though that is a statement, I would follow it up with, is that it? Am I hearing you correctly? Does that work? Okay, so there's always some kind of question at the end. Here's a bunch more. I just created this slide for you to give you an idea of how you combine the feelings and the needs to get at that empathic connection when someone is feeling or experiencing some emotional being triggered. It can also be used when people are really celebrating as well, but that's a whole nother presentation. The ideas that we're getting to is this. Of course, you make sense. This is really a very grounding and settling experience that when you shared something very personal and vulnerable with me, what we're looking for is the acknowledgement to be heard, to be understood, that I choice and that I am in choice and that I matter. Remember, those are the core needs. I get it. Of course, you would feel so strongly, or it makes perfect sense. Yes. Just quickly, we've got a couple minutes left. This is a case scenario, and what I want to do is read it quickly to you, and I want to practice just for a moment. So as we're reading this, be thinking of which feelings and needs George might be having in this scenario and begin plopping them into the chat box. George is a 70-year-old resident living with uncontrolled diabetes, lifelong history of having a higher weight, well-controlled hypertension, osteoarthritis managed with acetaminophen, and a prior stroke led to lower extremity weakness requiring a wheelchair. Staff assist him with most ADLs, some hygiene. He has full cognitive capacity. The family brings home-cooked meals, desserts each week, and George stores leftovers and snacks in his room, resulting in insocks. Blood sugars, when he allows them to be checked, vary wildly. He did suffer severe neglect. We know, he shared with us, as a child, was malnourished and often hungry. As he grew older, his body grew larger and he experienced bullying from peers, criticism from adults, and now he's been in your community for 2 years. So just very quickly here, trying to bring on board, what can you imagine? So let me put up, what can you imagine in that scenario? Any range of feelings that might bubble up that when you think about George. And if you come up with needs as well, I'll toggle between those two slides for us. Start putting in feelings. So the part of this scenario is that staff are frustrated because George is, and I'm going to say refusing. My language would be he's declining to have his blood sugars checked. So we know that there's helplessness. He's got a history of trauma. Jacqueline, oh, numb, frustrated. Amanda, keep them coming. This is good. It just takes practice to be looking at these. If you want to also start looking, Lorraine, embarrassed, hopeless, fear of not, yes, Kelly, fear of not having food or being cared for. Oh, that just gave me goosebumps. Defeated, uncertain. Lovely, everyone, lovely, lovely. So now you can see how we would begin to integrate. Now, in our next minute, pop in the needs. Look at the needs. Oh, let me switch slides for you. Let me help you out, support you. What needs might be unmet for George? You've given me a host of possible feelings that this human being might be experiencing. What are his unmet needs? Acceptance, purpose, autonomy, meaning. Oh, almost brings a tear to my eye. I love this stuff so much. Security, acceptance. Yes, yes, yes. Support. Bodyfulness. Oh, Amanda, yes. Bodyfulness, food, trust. Look at this, you guys. We've got it. So you begin to integrate these. Lovely. And I do need to turn it back over to Nikki, but at the very end, I just want to say this. If you get to a situation where you feel like you're outside your scope and capacity in this trauma screening space, just acknowledgement. There's no shame in that. What's empowering is to say to someone, I so appreciate what you're sharing. Right now, I do need to bring someone else in to help support me to support you. Okay, so there's no shame or blame in this. We are learning together and growing our capacity. So if you would, as we wrap it up here with Nikki, what's one little thing that you're taking with you today that you might see yourself doing? So Nikki, thank you. I pass it on to you.